So we started looking at the kits. You said it kind of was an ineffective audit. How did that get addressed so we actually got more data?
So we started with this audit where we just asked chiefs of police, sheriffs to submit data that they had. What we found out very quickly was that they didn't have the resources in many cases to go back and look. Many of them did not have any kind of data tracking system. So some of them had spreadsheets, some of them had paper logs, some of them had nothing. And so it was a lot of work for them to go back and collect the data. It wasn't important to some of them to go back and do that in a timely manner. They had other things going on. And so we struggled to get that data without some kind of mandate. But as we started to look at it more with this group, with the ISACI group, and talk to them about how could we get more data, there were ideas distributed about perhaps we make it mandatory in legislation, or perhaps we take other tactics. Maybe we offer help to these agencies to investigate, send people to help them to get the data that we needed to understand our problem.
In probably 2014 or 15, when I was a police chief in Nampa, and a young reporter by the name of Ruth Brown did a FOIA request for sexual assault kits at our police department and many others. And quite honestly, I was embarrassed and ashamed at the results of what I thought was at Nampa PD, where I was in charge, kits that were misplaced, destroyed, etc., really when they shouldn't have been. And it was a real eye-opener. I think it was an eye-opener for all chiefs and sheriffs and practitioners throughout the state of Idaho.
I think that our iKits, the Idaho Kit Tracking System, has really made a big difference there. That you weren't the only one caught a little flat-footed when those audits were done. And so Idaho stood up, swallowed hard, and said, we're fixing this. And we have to a great deal.
Absolutely. I will tell you, back then, I thought that was a big city issue. Kits were getting left on the shelves at, big city police departments, but not in Idaho. I thought we were doing a really good job, but the results were pathetic. And for that, as you said, we swallowed hard. I publicly apologize. But again, you do some damage to those investigations that you can't undo. So I hope that we've learned from those and we'll continue to improve in that process. At the end of the day, my goal as a police chief and as a police officer is to make sure that victims are not re-victimized or further traumatized in the criminal justice system. It's bad enough what happened to them. We as peace officers or other practitioners shouldn't be re-victimizing them just to make an arrest.
The very first piece of legislation set minimum standards for processing, tracking sexual assault kit evidence. The best thing we did in that legislation was the tracking. This state is leading the country in that.
We're pretty proud of that our program is out there in several states, and that it's easy to use and highly effective.
Yeah, when we put that legislation together, again, consulting with Matthew Gammon at the Crime Lab, recognizing this is an issue, how we track this evidence. And what it does is it provides, I think, agency for the person who's been victimized. All control is lost. They've taken this evidence in the most invasive, nurses are being caring, but this is a tough thing. And to not know where it is and what's happening with it can really feel awful. I think it's really empowering to be able to track where it's going along the way. And I do think it increases our own accountability. When we know that's out there, transparency increases accountability on all sides. So it helps everyone, not only the victim, it helps law enforcement, it helps health agencies, it helps keep us on track so there's no mistakes, or there's a reduce of mistakes, I should say. But that ISACI group, again, vetted it. What are we missing? What are the problems? What are the issues? And I can remember the bill, so that bill was process most evidence. And the tracking mechanism, I agreed to that because the tracking mechanism allowed us to collect data. So a few years later, we can see what impacts it's having. And at that point, we had data that demonstrated there were still too many kits on shelves.
Right.
So that was the data we needed to help people understand why we needed to test all unless there was specific evidence to determine that the crime didn't occur, right?
Correct.
That helped a ton, not only people who have been victimized, but it helped with the system.
Being victim-centered and trauma-informed is making sure that the victim is at the center of what we do. They're the center of our assessment. They're the center of our evidence collection. They lead everything we do. For every single step of our process, we get consent from that patient so that they know that they are the ones making the decisions as we move forward. And then being trauma-informed, making sure that nothing we do or say helps to or causes a re-traumatization to our patient. And it's a skill that's learned as you kind of go through the process and do more and more exams. It's one that's becoming more popular to be taught in nursing school. So people do have a good basis of it when they get out of nursing school. But it's something that we just constantly need education on and reaffirming that we have the skills to be trauma-informed.
Care of the sexually assaulted requires a multidisciplinary approach with strong collaboration to ensure optimal medical, mental health, and legal outcomes. Medical providers address the immediate health care concerns while law enforcement begins the thorough investigation, and advocates provide support throughout the long process.
Hi there, how are you doing? I'm Melissa, and I'm a victim advocate for a local community-based organization whose mission is to support victims of trauma. As a crisis case manager and a victim advocate, my role is to let you know about different resources in the community to best support you throughout this process. We offer services such as counseling, support groups, case management, court advocacy, and safety planning to make sure that you feel as supported as possible throughout this process. All of these services are free of charge, no cost to you. In addition to the SANE nurse who will be collecting the forensic evidence associated with your trauma, we will work together as a team to best address your needs and wishes and make sure they are well respected throughout your healing journey.
A major piece of beginning the recovery and healing is returning control and choice to the patient. In Idaho, we found we need to be a little bit creative to get this done.
Just because you decide to proceed with this physical examination, including the physical collecting of the DNA evidence, does not mean that you are required to press charges to law enforcement at any time, now or in the future. That decision is yours to make, and ours is just to make sure that you feel supported and understand all of your options, so if the time comes, then you feel that you can make that decision for yourself. You also have the opportunity to work with a victim advocate that works for law enforcement in case you do feel like you would like to proceed legal action in the future.
As I'm teaching SANEs across the state, I strongly encourage them to say to the patient, I'm calling Jane to come in and talk with you. She's an advocate and can share with you the services she can provide. After you've spoken with Jane, you can decide whether or not you want to use her services.
As a crisis case manager and a victim advocate, my role is to let the victim know about all resources available in their community, resources such as case management, counseling, court advocacy, safety planning, and even safe shelter if need be. All of these resources are free of charge, no cost to you. We do not judge actions or decisions. We are here just to make sure you feel supported throughout your whole healing journey. We do not care about legal status or nationality. We just want to make sure that you feel supported as possible and that you can make the best decision for yourself.
And so for the nurses, what kind of education do you have to be a SANE nurse? Because it sounds like we've got to learn about victim-centered, trauma-informed, and then kind of what exactly is the position and what does it take to get here?
So you have to be a registered nurse or a licensed practical nurse by a state board, whether you're in a compact state or a non-compact state. You have to have a licensure from the board to be able to work as a nurse is the first step. Most programs like nurses to have emergency medicine background, whether they're working in the ER or in a critical care access, or even in a critical care field such as ICU. But I think that kind of limits us in what we can get from the nursing field, because people can do so much more for forensics when you don't have that background even. Like, it's not I don't really think it's a requirement. They do tend to see more of the traumas, so they are a little bit better at the trauma-informed care. It's a little more natural. But all nurses have that basis for trauma-informed care.
So talk a little bit about the training that you had to undergo to actually work as a SANE nurse. You have to be a registered nurse.
Yep.
And then what training do you do?
So we here at the Domestic Violence and Sexual Assault Center go through the International Association of Forensic Nurses, and we do their 40-hour SANE training for both adult and adolescents and pediatric and adolescents. So they have a 40-hour for adults and adolescents and a 43-hour for pediatric and adolescents. We usually start with the adults. We go through that training, and then we have proctored exams. So we go out to exams with another nurse who is working independently and is comfortable in their practice. And then we slowly learn those skills. We also have skill days here at the Domestic Violence and Sexual Assault Center, where we focus on those skills of learning how to collect swabs and the proper technique to swab, and learning what bruising we're looking for or differentiating injury. So there's a fair bit of training that goes into it. If you're willing to stick through the process, it's very worth it in the end. It's hard because we never know when a case is going to come in, and so it can make an orientation last a very long time.
Never knowing exactly when you're going to be called in to do that.
Mm-hmm. And as you train these nurses, I mean, usually they're going through their first 40-hour course on being a sexual assault nurse examiner. I mean, how does their reaction change? How does the dialogue change as you provide education from the law enforcement perspective?
Oh, I love it. When I get to hear a nurse asking trauma-informed questions when we're out at a hospital. Actually, ironically, not even a month ago, one of our sexual assault nurses is now a nursing professor at Boise State University. And she is still on our sexual assault team, but she said, our students need to know about trauma. So I spent 2 hours teaching a nursing class, and I'm scheduled for next semester. And I said, I'll come back as many semesters as you want. I'm actually working on getting into NNU to teach their nursing students about trauma. I think every profession that whether it's paramedics, firefighters, who I've also trained in our jurisdiction about the impact of trauma, I think anybody who is going to be working with a victim as a first responder or as a service provider should have trauma-informed training. And I am so passionate about providing that and getting that out there. So when our sexual assault nurse, who understood the value of it and the work she was doing, said, all my nursing students need to know this, I thought that was fantastic.
So as you talk about collecting evidence, as a nurse, it's important that we focus on health care. So can you talk a little bit about how that exam transitions from healthcare into the forensics piece of the exam?
Sure. So we go through and we do a basic medical history. We ask our patient, have you been diagnosed with anything? Do you have any allergies? Have you had any recent surgeries or injuries that you know about? We ask about their activities of daily living. When's the last time you used the restroom, brushed your teeth, taken a bath, that kind of stuff. We even ask when their last consensual sexual interaction was, because that all gives us a timeline of where we're coming to. So then we start to become more focused. We asked for a detailed history of the events for why we're seeing the patient. We then take that history and the specific questions that we ask around that history and turn it into what guides our exam. So every patient that we see gets a head-to-toe exam, much like they do in a doctor's office. We check their eyes, we check their ears, we check their nose, we check their mouth, we listen to their heart and lungs, we listen to their stomach, making sure they've got active bowel tones. We look at their skin for any injury. We palpate the head. And we just literally go head to toe like we learned in nursing school. But then as we do that exam, we're looking for the injuries that they reported to us or that they said may have occurred during this event. And so as we find those, we then photograph those injuries, and we do those in a 3-stage series usually. We take an orientation photo, so we take one so we know where it's at on the body. So if they end up with a bruise on their arm, their forearm, we want to make sure that we get maybe their ear or their chin, their shoulder, and then the distal part of their arm in that as well, so we know what side of the body that injury is on. Then we're going to come in a little bit closer and take a more detailed photo of that injury. And then we're going to take an even closer photo with measurements so we know how wide and how long that bruise is. We're going to comment on what shape it is. We're going to comment on what color it is. We're going to know if it's tender or not. And so those details, as you get into that, is where we get into the forensic aspect of things. If they say they had prolonged contact on that area, we're going to make sure we swab that area, because the lab can get touch DNA from prolonged physical contact. So again, taking it into that forensic level where we're attempting to get DNA evidence off of an injury. And we do that for the whole exam. If we locate an injury, we document it, we quantify it or qualify it, and then we swab it if we deem that to be necessary.
And so all of that, as you mentioned earlier, the patient consents, and so that's kind of a fluid consent going through the process. What if you get partway through that and maybe get down to doing the real personal part of the exam on the anogenital area, and the patient says, I don't think I want to do this anymore?
Then we stop. It's that simple. If they say that they're not comfortable, I'm not going to push that envelope. Like, that is not trauma-informed care. Me saying that's okay is actually a great way for them to start taking control of their body again and letting them have the autonomy to make that decision. And I can inform and educate on how getting that DNA could be helpful to the case and how we don't have it. We may not have as strong of a case, but that's also okay, because we can also educate on the fact that we have 5 days to collect this evidence. So maybe today is day 2 after the assault, and they're not up for it, and that's okay. I can say, well, go home, sleep, eat, take care of yourself. If you change your mind, call us, and we have 3 more days to attempt to collect this evidence. And if after that 3 days you're like, something just isn't right, I would just like it to be looked at, we'll look at it. We'll take photos at that point in time. That's okay too. Like, it is not usually make or break in any case, like whether we get those DNA swabs from the anogenital area. Does it help? Yes, but is it absolutely mandatory? No. And if it's better for our patients' peace of mind and their ability to heal to not have it done, that is 110% okay.
So it really is patient-driven, which goes back to being victim-centered.
Yep.
So when you do an investigation, very often what you have is he said, she said.
Yes.
What does that look like when you really don't have hard evidence like you might have in some other cases?
Okay, yeah, that does make it much harder. So part of that comes down a lot to the interviewers and the interviewing techniques, in my opinion, because even the sexual assault kits were done. If it's the he said, she said, it might say it happened, but it doesn't necessarily say how it happened or the why, where there was the nose in there, was it forced? And from that, though, I'm going to go back to the sexual assault kits. What I really prefer and like is I trust our forensic nurses. That to me is key, one of the big components, because they do that interview with them as well besides us, and they are documenting the injuries, and you need to look at that report. I think that tells you more of what happened and is more key to the investigation than a lot of other things. Other than that, when we talk to the victim, you always believe the victim, get the story, and then we just document what they say, try to get the most out of the interview, and then forward it to the prosecutor's office, but working together.
For example, our anonymous kits now, because of legislation, are kept by law enforcement for long-term storage for up to 55 years. I think that's probably one of the longest time frames across the nation.
Yeah, Idaho is a trendsetter there, and that didn't come from me, and that's what I tried to explain to folks when I introduced the legislation. I served as a facilitator of that team and gathered input. Angela Weeks, a detective, was great about providing research and best practice. I remember the Sheriff's Association was at the table, the chiefs of police, you name it. And there was some initial discussion and not quite agreement, but after we put all that best practice, and in particular what we know about trauma, if somebody is reluctant to report, if they know they could preserve the evidence and maybe come back when they're more emotionally capable, all the better to save it. And so I was really proud of our team. I mean, I think we set model legislation for the whole country on that.
So we know that we think that probably less than half of the assaults that happen in our nation, and certainly in Idaho, are actually reported to the police. Do we ever have patients come in and say, I want to have an exam, but I don't want to talk to the cops?
We sure do, and we call those Jane or John Doe exams, and that's a pretty nationalized term. And so it's the same process whether you are reporting to law enforcement or a Jane Doe or John Doe. You're going to get the same level of care. We are still going to go through and take your statement. We're going to take your history. We're going to do that head-to-toe exam, and we're going to do the evidence collection. The difference is your name, if you are choosing not to report, doesn't go on that kit. And the report that we collect, at least in our practice, does not go to law enforcement until you choose to report. So we make sure you have your kit number. We make sure that you have the contact information here so that if you do choose to report, you can take that information with you to the law enforcement agency that you're reporting to and say, I've had this done. Here's my kit number. Here is the contact information for where I had this exam done so that we can then get the information to the appropriate law enforcement at that time.
Well, I think part of the unique thing about Idaho is we have very small counties with few officers and not as many than you have the greater Ada County, Boise area, which have totally different protocols than we do because they have more resources. So part of that depends on where you're from.
What are some of the challenges you think that we're seeing across the state as we attempt to address sexual assault?
Well, speaking specifically for South Central Idaho, geography. Geography is a huge challenge. Now, as I mentioned earlier, most of my career was in the city of Nampa, and we were very, very blessed to have a really good hospital system, first with Mercy Medical Center, but also our partnerships with St. Alphonsus Regional Medical Center and St. Luke's Regional Medical Center in the Boise area. And now, of course, they've expanded out into Nampa. But here in South Central Idaho, in Twin Falls, the St. Luke's Regional, Magic Valley Regional Medical Center here in Twin is really the main hospital for the entire Magic Valley. So when we have a victim who walks in, as an example, to the Lincoln County Sheriff's Office in Shoshone to report her or maybe his victimization, if they need medical treatment, they're going to need to travel. And furthermore, they may need to wait for an extended period of time for a trained detective to come out to talk with them, to obtain victim services, court services, all those sorts of things. So geography is an impediment that we see here in the Magic Valley. We're pretty lucky in the city of Twin Falls, being one of the bigger cities of the region, but for our partners that we work with day in, day out, even in Jerome County, Lincoln County, Gooding County, and even some in rural Twin Falls County, they're not as fortunate as we are.
I think that's a really key thing to understand in a state like Idaho. It's not just that southeast part of the state as well. Even some of our other counties, when we talk to them, getting victims to a place where they can receive services, especially in a timely manner, is a big barrier. So
absolutely. We have statutorily changed how we handle the sexual assault kits. And part of that, as you are aware, is that a victim has the right to have an anonymous kit done and then collected anonymously by law enforcement and stored up until the time that maybe they may want that kit tested. That was a little more difficult than I think any of us involved at the legislative level than we thought that would be. There were a lot of, I would say, wires getting crossed, right? Once a hospital would think that maybe we need to notify law enforcement now while said victim is in the room. And the unfortunate thing is once you ring that bell and an officer gets that name, you can't unring it. And so we did work through that. And a lot of that was because of the great leadership at St. Luke's here locally, and I'm sure throughout the organization. But as one of the folks involved in that legislation, working specifically with Senator Winthrop, I don't think we anticipated that being as big of a hurdle, and maybe it wasn't, and I know talking to my counterparts throughout the state, we all felt that a little bit. And I think we've worked through that. That hasn't been an issue. We've worked through the tracking mechanisms. I think our prosecutor here in Twin Falls County and other prosecutors understand their responsibility in regards to tracking of sexual assault kits, and giving an explanation as to why, specifically why a kit will not be used, et cetera. So we've come a long ways.
I think you kind of hit it right there too, is that success may look a little different for each victim.
Totally true. And what their goals are is totally individual. And so our hope is to see that their goals are fulfilled for what they need and want. But some of that may just be being believed, having access to resources, having a no contact order with somebody that's for a really long time so they don't have to have that, getting that person removed from their life, making sure that they're safe. Success, there's lots of successes aside from a conviction at trial.
And I think that's important for us all to recognize. And as we have those conversations and build those relationships, it becomes a little easier to see those smaller successes.
Exactly.
We have a bunch more and excellent questions coming into the chat. So Matt, you've got your work cut out for you.
Fantastic. Thanks, Tyler. So we want to address a few things really quickly. So this is being recorded. Our partners there at FTCOE will make this available. It'll be archived for people to go back. We did that intentionally because we wanted to have this video available. Many people ask us questions about what does a sexual assault kit look like? What does an exam room look like? Things like that. So we tried to make these videos so that they would be useful to you when you have meetings with policymakers and others that are trying to make critical decisions on these things. Now, we did film at the Women and Children's Alliance in Boise. That was our victim advocate that many of you are commenting in. She's fantastic. If any of you are interested, the executive director there is Veronica Salazar, and we can get her contact information for you. But that is not a real survivor. That is not a real victim of crime. We used actors for everything that we did. Anyone that was acting a role was not a real individual in that role. So you're welcome to use all of these videos out as examples. I will just talk, Paul asked a question about statutory, and I will say that we did have no limit of statute. We had no statute of limitations for sexual assault in Idaho when we've been doing all of this work. So that needs to be on the table. But I will say that we changed several laws that you're hearing discussion about now on the webinar, specifically to mandate kit tracking, mandate hit tracking of CODIS hits, mandatory kit retention. I have to give a report to the legislature anytime we have a kit that hasn't been tested within 90 days. We have a legislative report on kits not submitted to the lab within 30 days. And then we also had legislation passed on not charging the survivors in these cases, not charging their insurance. So making sure that those things were all paid by state resources. So those are all examples of legislation, and there's more information we can provide on those if anyone's individually interested. So let's move now. A question coming in from Cody, and I think we'll toss this to Tina of our panel. Do we have a chart of the process? So if a survivor comes in and wants to know what the process is, do we have something like that?
We do have something like that. We have something that charts the process for the victim of the crime. And then we also have something that outlines the process for our SART team members. So everybody understands who's doing what when they're doing it and why they are doing that. So those are things, and we can share those. Anything that we have developed, we will gladly share with anybody. As a matter of fact, I'm just getting ready to send an email to somebody else on another question. So we do have that information and we will gladly supply it back.
And I'll tag on to what Tina is saying, that we will gladly share anything that we've talked about on this webinar today, including our sexual assault kit tracking software, including forms or anything else that we have. We will make that available to you. So please ask, we're happy to share. Let's toss the question to coming in from Stephanie. So the question coming in is patients and victims or survivors turning down services and what we know in our state.
I don't know what we know statewide. I can tell you what we are tracking here, and we are tracking that information. Both with my Bird JAG grant and my United Way grant, I have to report this information back. And what we're tracking is, you know, if it was the client or the patient themselves who chose not to follow through, you know, maybe they just came in for what we would term a wellness exam or a head to toe exam. They don't want anything else done. Because they're an adult, that's an option. You know, so, and like in this last quarter, we had 2 of those cases. But, you know, as far as on a statewide level, and is anybody tracking this information? I don't know.
And let's toss that question to Angela. Angela has retired as a detective for the Nampa Police Department, now working with the Family Justice Center in Nampa, Idaho. Angela, do you have any thoughts there?
You know, I don't have any statistics for people, but I know that it is, we see a lot of people coming into the Justice Center for services that don't want to go forward with any part of the criminal justice system. So making sure we have both options available for victims at any point in time is crucial.
Thanks, Angela. A question coming in from the victim services team, I'm going to toss to Deb on sustainability.
Absolutely great consideration, right? As we talk about Idaho being a rural state and there's not a lot of SANEs to start with, how do we make sure that these nurses stay active? One of the things I do right up front when I start my teaching is I say to these nurses, number one, I'm glad you're here. But if at any point during this week you begin to realize, I don't think this is for me, it is perfectly acceptable to go. One of the worst things that we could do is try to push someone into doing this work who isn't ready for it, because they're going to be highly traumatized themselves, and it just doesn't work. So first of all, setting some realistic expectations. And then we do talk heavily about vicarious trauma, that we as healthcare providers, as law enforcement officers, as advocates, we assume some of that trauma, some of those feelings from every single person we interact with. And so we talk a lot about how do we keep ourselves mentally healthy? How do we take care of ourselves? Because if we don't take care of ourselves, we're not going to be able to be there to take care of the patients. And I do encourage the programs across the state to address, and I believe most of them do, on a routine basis with their nurses. Make sure that you have a sane buddy that you can talk to and just kind of get it off your chest, if you will, when it's been really tough. So really taking strong steps to take care of yourself. Of course, by providing more education across the state and training more nurses, that spreads that trauma out a little bit. I worry very much about some of our smaller places that only have a couple of nurses who are doing this work, because at some point we all just reach a saturation level and can't continue anymore. So really trying to get more nurses trained, reaching that 250 goal, our SANE 250 goal and beyond, will help kind of dilute the amount of trauma that each nurse is absorbing. So those are some of the things that we're doing. If anyone else has any really great things you're doing out there to address this, please get a hold of me.
And I think on a functional level, we are looking at sustainability for your position. We've realized how critical that is. So our legislature hopefully is going to be able to help us out with that continuing funding for your physical position. We're looking at what resources do we need to have in the local collection facilities? Do they have cameras? We provided that early on and we think we met that need, but as more centers come on, we'll have more needs there. Also, we need to revisit what's happening in those centers to make sure their equipment is up to date. So that is a big part of this sustainability plan. One of our concerns we addressed 2 weeks ago was talking about what's happening with COVID and the turnover in the hospitals with our nursing staff. and how do we compensate for that, and how do we ensure that our training programs are matching the turnover in our nursing staff. So great considerations. Keep those great questions coming in. We have at least one more segment where we'll be discussing questions. So we'll turn it back to Tyler for more video.